Good evening and welcome to the first lecture in the 2013 series, Global Diseases, Voices from the Vanguard, which, as I think most of you know, is a joint effort between the Center for Tropical and Emerging Global Diseases and Professor Pat Thomas, the Knight Chair in Health and Medical Journalism in the Grady College of Journalism and Mass Communications. So thank you for coming and helping us start this 8th year of Voices. Hard to believe, isn't it, Pat? But our 8th year. And the intent of this lecture series is to try to increase and broaden the interests in global health research and global health across the breadth of the UGA campus. And tonight's lecturer is a great person to start us off doing that. But before I introduce her, let me first remind you that directly following tonight's lecture, we'll have a reception in Demosthenian Hall next door. And then also looking ahead, please note that the next Voices from the Vanguard lecturer will be on Monday, February 11th, and it will be Dr. Jose Esparza, the Senior Advisor on Vaccines at the Bill and Melinda Gates Foundation. So tonight, you're in for a treat. Dr. Michele Berry is, from my perspective, global health writ large. For many Yale University and now Stanford University medical students, she has been the face of global health. She's been the one that often got them interested in global health, and she's clearly been the one who continued to foster that interest, making global health experiences a reality for hundreds of them. And those of us in global health know that once you go, you're usually hooked. And so that's a really important role. So in regard to global health, Michele is a physician who has been there and done that, and has also gone on to lead many others to do that. She earned her AB degree at Bryn Mawr and her MD at Albert Einstein, and got a diploma in tropical medicine from Walter Reed while doing her house staff training at Yale New Haven Hospital. She stayed then, and I thought she would be there forever. However, in 2009, after almost 30 years there, she up and moved to the West Coast and, I don't know, traded in her galoshes or something, and I don't know what she did with them. So at Stanford, she's the Senior Associate Dean for Global Health and the Director of the Center for Innovation in Global Health, which is, I think, pretty interesting, and I hope we hear something about that tonight. Michele has received many honors related to her expertise in both medicine and her focus on global health. And I'm just going to embarrass the heck out of her. She's the past president of the American Society for Tropical Medicine and Hygiene. She's been recognized by Catholic Relief Services with their Humanitarian Award for her work with refugees. She was a recipient of the 2010 Ben Keane Medal, which in the American Society for Tropical Medicine is really a big deal. And she's an elected member of the Institute of Medicine of the National Academy of Sciences. Never one to shirk responsibilities, Michele is also Senior Fellow of the Woods Institute and an ambassador for the Paul Rogers Society, where she endeavors to educate members of the U.S. Congress. Now there's an ambitious woman. Someone not undaunted by the obstacles confronting her. U.S. Congress is tough to educate sometimes. Michele's current areas of primary interest have focused on global health, the workforce for global health, problems of underserved populations, and the impact of globalization on the developing world and health in the developing world. I think this last area may be a part of what she wants to tell us about this evening. So without further ado, please join me in welcoming Michele Berry to UGA.
Dan, that was an uncalled for introduction. But I would like to thank Dan and Pat for inviting me to this institution to give this talk and to this Vanguard series. Dan asked me to actually, let's see if this goes, to give a talk. But before I give a talk on what I'm going to call the eggs, you're going to think, what is this crazy lady talking about, eggs? He asked me to talk a little bit about myself. And so I picked 2 slides to talk about myself, because he talked way too much about myself. But this is the reason why I went into medicine. This is a picture of my friend's baby with a baby at exactly the same age. I went into medicine for political reasons, to try to make a difference, to work with underserved populations. So I figured 2 pictures really, the second picture I'll show you also says it all. The second picture I'm a little embarrassed to show, because it's the first time I ever went out in the field. And I'm sitting there with a very close friend of mine. I don't know if anybody knows Dr. Sally Stansfield. And Sally went on to go on to CDC and the Gates Foundation, where she started global health fund grant making. She went then on to WHO and then to Deloitte. I, as Dan said, didn't have such a peripatetic career. I stayed at Yale. Now, how do you do tropical diseases at Yale in New Haven was something that I had to grapple with. And when you're making a 2-career family decision, and I was in New Haven for my husband, I managed to cut a deal with Yale. I cut a deal where every 3 years I would take a semester off and go work in an underserved area. So my children were actually raised in Zimbabwe, in South Africa, in Ecuador, so that every triennial I weighted down and got out into the field. So if I can say anything to you about doing global health, it's really get out there and get your hands dirty or wash them. So what am I going to talk about? Those are my 2 slides. That's all I'm going to talk about myself. But what I'm going to talk about today is what is global health? I mean, people always ask me, what do you mean by global health? It's such a broad area. So I'd like to talk to you about what I think my definition of global health is. And then eggs, what I call the eggs and what I've written about for several years are these egregious gaps that have occurred with globalization. And I'll talk to you a little bit about what I think these are. And then how we go about cracking these eggs and potential future solutions. So global health, why is this, many of us have been doing, and I know there are many in the audience since I've talked to them, I've been doing tropical diseases and global health for many years. There's really been a paradigm shift in thinking, and I don't think it's a fad. The consortium, I sit on the board of the Consortium of Universities for Global Health, and we did a study which showed that 72 universities in the US now have 302 long-term training and education programs in 97 countries. That's a huge amount of training that's going on, and this has really been in the past 10 years. And in the past 10 years, 41 universities in the US have created the new Global Health Institutes, or Centers for Tropical Emerging Diseases. And we're calling this generation the G generation, where it's all about global health and global health equity. Now, why is this happening? I think this is happening for several reasons. I think there's a tremendous amount of global interconnectedness with the media and the social media. I think we have tremendous mobility and a concept of global citizenry. I think the web space has made an immediacy of issues in your face. I was just talking to Pat that I just started this fellowship in global health and journalism because we need to tell our story persuasively, and we need to use that web. I think this generation is the first generation to actually have lived through the HIV epidemic, and they see this pandemic viruses that occur, such as SARS and influenza. And then I'll spend a few seconds about my eggs. But I think that global health aid, which yes, it has dramatically increased from $5.6 billion in 1990 to $26.8 billion in 2010, is not the cause of this interest. I think it's following this interest. I think it's really, and if you look at the gorilla in the room, which is the Gates Foundation, you can see Gates started around here, but it's really all of the developmental NGOs and bilaterals and multilaterals have increased their, really their interest and funding in global health. So it's not just the Gates Foundation. And the NIH has gotten into this. I was at a talk with Francis Collins where he said global health is one of the 5 priorities for the NIH. And I liked his quote that global health can make us more of a doctor to the world than a soldier to the world. So in my mind, global health is an ethical imperative. And I think our government has also invested in this with PEPFAR being the Presidential Emergency Relief Plan for AIDS, and a global health initiative. And you can see that partnerships are crucial. So what do I mean by global health? So I myself, and this is, if any of you are interested in reading the piece by Jeff Copeland in Lancet, which talks about the definition of global health as really being an area for interdisciplinary study and research and practice that places a priority on achieving equity in health. So this resonates with me, because that's what I went into medicine for. I think it's what many people do basic science, do global public health. It's all about equity and access. It may run around the Millennium Development Goals, and everybody knows, I'm not going to spend any time talking about these 8 goals, which it's almost 2015. We'll be hearing quite a bit about how we've progressed in achieving these goals soon. But even though there are only health for child mortality, improving maternal health, and combating HIV and AIDS, I would argue that all of the 8 Millennium Development Goals really are derived around health. I mean, you're not going to get healthy unless you eradicate extreme poverty and hunger, and you're certainly not going to get healthy unless you promote gender equity, and I'll talk to you a little bit more about why I think that's important. But let me tell you what I think is the missing agendas in the Millennium Goals. So those are all wonderful bread and butter, apple pie goals, but I would like to say that what's not mentioned in those goals are the chronic non-communicable diseases or the social determinants of health. There's very little mention, there's no mention of tobacco, which probably kills more people than TB, malaria, or HIV. Road traffic accidents, and I'll show you a little bit about that in the new Global Burden of Disease, which just came out this week in Lancet. Mental illness is not mentioned in that, and if you look at the Global Burden of Disease, you'll see that that's one of the big disabilities that we live with. War and post-conflict, and what happens in those settings. Climate change, and I have to say, I came with a coat to Georgia. I'm just amazed that it's 75 degrees here. Climate change and health sequelae of climate change. And then workforce maldistribution, which is an area where I've worked on for the last couple of decades. But basically knowing that places like Africa, which has 25% of the disease burden, really has only 4% of the health workforce. And that just ain't fair. The world is, well, what I'd like to talk to you a little bit about is this Lancet, and if any of you have time, the January 4th issue of Lancet is Chris Murray's pièce de résistance of the global burden of disease for the last 20 years. And really, over 500 investigators worked on it. But I tried to, it took me many, many, many hours to read the issue, but let me just boil it down into a thumbnail. The thumbnail is that the world has grown much older. In fact, in the last 50 years, we've increased our life expectancy more than the last 5,000 years. Did you hear that? The last 50 years, we've increased our life expectancy more than the last 5,000 years. The other thing to know is that 2 out of 3 people are now dying from non-communicable diseases, so that more people are dying of heart disease, cancer, and chronic disorders. And then I think very tellingly, is that the disease burden is increasingly defined by disability instead of premature death. And another amazing statistic, and I know it's a number, but 50% of people living over the age of 50 are living with a disability. And that might be depression, it might be low back pain, but we're living longer, but we're not necessarily living healthier. And this, to me, are the take-home messages. And I'll give you, if you get a chance to pull this issue, you can play with these graphics, and you can go on the web. This is the change in the leading causes of death between 1990 and 2010. And to me, the big take-home points that came from this is that HIV was ranked 35 as a cause of death in 1990. And again, 2 out of 3 deaths is due to non-communicable diseases. And if you look at diabetes here, where is diabetes? It doubled. And what is a diabetic death? I mean, it's very hard to say what a diabetic death is, because I assure you that some of these ischemic heart disease and stroke are miscalculated as diabetic deaths, so that we're probably underappreciating what's going on in our society with diabetes and obesity. But even though non-communicable diseases play such a huge role, and if you do pull that issue, really what we're putting into money for our global health initiative is really AIDS and malaria, which of the 63 billion, 51 billion, and other global health priorities are only about 12 billion. Those other diseases, and meaning those other diseases that I told you about for the chronic non-communicable diseases, but I'd like to tell you, and I know Peter Hotez talked to you already, and I have to tell you a little bit about this because this is also my passion, is that neglected tropical diseases are those other diseases. And those are the diseases that are most prevalent amongst the poor people and endemic in rural areas, and are really the ancient biblical diseases that are chronic and disabling and have a high disease burden and are stigmatizing and poverty promoting. These are the diseases that your center, Dr. Colley, studies. And diseases such as schistosomiasis, elephantiasis, or guinea worm. These are diseases that we need to start paying attention to and put more money into. So with that background, I will talk to you a little bit about what I think are some of the eggs that have occurred with globalization, because as we globalize and as we travel, what's happening, what are the gaps that are occurring even more? And I'll talk to you a little bit about the healthcare gap, the pharmaceutical R&D gap, the literacy and digital divide gap, the water and sanitation gap, and the health workforce gap. These are all things that I think have gotten larger as we globalize. So a few words about healthcare expenditures. The expenditures in the United States now is up to $2.6 trillion. We spend about 8,000, well, not about, I looked it up and updated these slides. As of this week, $8,233 per capita. And it shows that 89% of our global, almost 90% of global expenditures on health care goes to about 20% of the world's population. So is this a good thing or a bad thing that we spend that much? Well, I thought that there's a little nuance in this, that even though this gap is increasing, if you look at 3 countries whose life expectancies are about the same, Japan, Costa Rica, and Cuba, life expectancy of Japan is about 83, Cuba 79, and Costa Rica 79. You can see they spend very different amounts per capita. So it's not necessarily how much we spend, but it's how we spend it. But clearly, access to drugs, when you look at the pharmaceutical gap and where we're putting our money in for development of pharmaceuticals, you can see that almost 80% of the world drug market, and this is a big, big amount, $1 billion, comes from North America and Europe. And it's really, the world population is just not living in North America and Europe. It's all about living in Asia. So you can see that this is directed to a very small portion of the pie. And I think that we need to reflect and have some ethical discomfort, because many of us, even though they're putting a lot of attention on new drugs, we're outsourcing this research. The number of non-US countries serving as FDA trial sites has doubled in the last 10 years, whereas we've actually gone down by 20%. So that we should think about what drugs we're testing overseas. Does it have cultural relevance to that setting? This is an area where I've written in. What does it mean to have informed consent in the developing world where it's a different culture? What kind of IRB transparency do we have? There's a tremendous local brain drain to these trials. And then the genomics for these drugs may not be able to be generalized. So to me, it's a very interesting gap that we're creating. And then the other thing is distributive justice. Are the drugs that we're testing overseas, are those drugs available to the subjects at the end? So these are all areas that I think are very important. And I'll give you a little vignette about this, which is about African sleeping sickness. Oops, sorry. And the rise and fall of African sleeping sickness. Now, Dr. Colley and I were talking about some of the wonderful things that pharma does about donating drugs, and there's no question that to the neglected tropical diseases, they've been a big player. But I got involved with this when I was past president of the American Society of Tropical Medicine, and the fact that in the 1990s, eflornithine, which is a good drug for T. gambiensis, was taken off the market. It was taken off the market because it wasn't making a profit. And then about a year later, it came back on the market as a facial depilatory in the United States. It actually helps take away facial mustaches. A lot of us got together, MSF leading the way, Médecins Sans Frontières leading the way, ASTMH was part of that, where we actually put a lot of pressure. And I have to say, Aventis Sanofi came through, and they donated eflornithine after a year of being off the market and synthesized as a facial depilatory and put it back on the market as a treatment for sleeping sickness. So that in 2010, which is the latest thing, which I just updated a couple of days ago, and I'm sure this is a gross underestimation, because that's just of the reported sleeping sickness. There are about 7,300 infected. Another gap that I'd like to talk to you about that's growing with globalization is the literacy gap and health. And why is that important? Well, adult literacy is defined as the ability to read and write over the age of 15 by WHO. And 25% of the world's population is illiterate. And 75%, even though only 25% is illiterate, really the majority of the world lives in an oral and visual culture. So does this make a difference in health? Well, it does make a difference in health. And if you look at female literacy rate, you can see that there's a direct proportion to female literacy rate to fertility rate. And it's really quite striking. And it shouldn't surprise you, in my mind, that the more literate a mother is, the easier it is to read about how to keep your child healthy and safe. And statistical significant association for maternal literacy has been found for under 5 mortality, for infant mortality, and the risk of low, mid, upper arm circumference, which is just a malnourishment marker. So something to think about, how literacy and that gap in literacy plays a role in health. And I think you can't think about literacy without thinking about illiteracy, what I'll call illiteracy, or the gap that's occurring with globalization. And so this is globalization and the digital divide, or what I call illiteracy. And even though 88% of all internet users live in industrialized countries, 4 out of 5 websites are in English, with 1 of 10 people on the planet only speaking English. And here, another very interesting thing, but I think we have cause to be happier, is that 12% of the world's population is in Africa, yet only 2% of the telephone landlines. But thankfully, we have cell phones. And so when we have, I think, the growing gap and the way this gap is really playing a role in health will be through the cell phone, where there's even though we have about 5.6% internet penetration in Africa, we have 1 billion subscribers. And if anyone's been overseas, which probably all this audience has, you know that cell phones are being used for health. And I thought I'd throw some of the examples of some of the cell phones with health. So on the top is what is happening in UCLA and Berkeley, the lens-free microskia, which is a way, this is a fascinating thing. They've hacked into a smartphone so that you can actually use the camera on the smartphone to take malaria smears and then actually transmit that back to the mother computer so that you can actually identify in the field malaria smears and plasmodium. We have frontline SMS testing, which basically we can deliver test results with SMS texting for free. It's a great group run by Ken Banks that's doing that. For those of you who grew up on ProMed, Health Map is the next iteration where basically you can every day map onto Health Map and see what outbreaks are happening in the world, reporting and viewing disease outbreaks. There's Cell Life that works in HIV, home-based HIV care with cell phones in South Africa. And then ASHA, I thought was interesting to give you an example of how to monitor directly observed therapy for TB. With just where actually community healthcare workers go out and actually not only put the information into the cell phone, take a picture and do the directly observed therapy that way. So really interesting, creative ways to diminish that gap, that digital divide gap. So even though we're not on the internet, I think the major intervention is going to be in cell phones. And I thought a kind of interesting example of a cell phone initiative that my Stanford students have done is around the politics of water. And I know you had Jenna Davis speak at this, this Vanguard Voices, and she talked to you about how millions of women and girls spend up to 4 hours a day walking and collecting water. And she probably told you that 2.6 billion people have no access to sanitation, and that 50% of all people in the developing countries suffer from a health problem due to water or sanitation. So I think this is a great class. We have a class called Liberation Technology, where what we try to do is how can that cell phone make a difference in health? And this is a collaboration between the University of Nairobi and Stanford students, where we randomized novel mobile phone application in Kibera. Kibera is the largest slum in Kenya. It is, at any one point, millions of people are in and out of it. And the goal was to evaluate, and the way that water is sold there, it's sold in these little, if anyone's been there, you've seen these kind of plastic bags that water is sold in. And so what what this project was, is that the vendors, this app was made, and because everybody has a cell phone in Kibera, you can actually have the vendors advertise on the app where they have water to sell and the data purification for that water. And then users can sort by geography, prices, and quantity, and give them a rating, kind of a Yelp rating. And then vendor ratings are generated by the users, and they get feedback into a database. What we're trying to do is to see really if this impacts the marketplace, if it impacts water prices, if it impacts episodes of diarrhea, and even the distances that people walk. We put GPSs on their water cans to see if this app will make a difference in how much they walk for water. So really an interesting way to use mHealth to liberate and diminish this, what I call an egregious globalization gap. The last gap I want to talk about is back to this picture, which I'll go very quickly past, which is about the health workforce gap. And this is about that big maldistribution that I showed you, where 25% of Africa has the disease burden, but only 4% of the doctors. And you can see that the ratios of doctors are really amazing. When you have a place like Malawi, where it's 1 doctor per 50,000, and believe me, it's not doctors that matter. It's community healthcare workers, it's nurses, and when you take in those management people, these numbers go even astronomically higher. And when you think about healthcare workers, there's a critical, and this means not just doctors, there's a critical shortage of them in 57 countries, and a total shortage of 4.5 million healthcare workers globally. And so that's where I'm talking about those other folks who are, to me, even more important in the developing setting. But I do want to spend a few seconds about doctors, because that's what I do, is I send doctors to underserved areas around the country, around the world. And I'm embarrassed about doing that, because we're part of the problem. We are 25% of our workforce in the United States is actually foreign trained. So we are part of the sucking noise of taking physicians from the workforce and bringing them to the United States. And what I think is amazing is that these physicians are actually not our subspecialists. They're our bread and butter physicians. If you look at where these, I sit on the board of the Foundation for Advancement of International Medical Graduate Education. If you look at where these folks are, they're 37% of our US internists, they're 28% of our pediatrician, and they're 27% of our family medicine physicians. These are the bread and butter, oops, I love it, let there be light, because I think there needs to be light on this subject. These are the bread and butter of our health professionals. And if you add 32 more million people, which thank God Obama has gotten, we're hoping we'll see this, who's going to be taking care of those patients? You're going to see a lot of need for more international medical graduates. So how can we actually crack this egg? How can we make a difference? And I think the way we can crack this egg is task shifting. Task shifting of, you know, doctors are just, we don't have to do everything with doctors. We can do this in teams. We can do this with community healthcare workers. We can do this with PAs and nurse practitioners instead of the usual MDs and RNs. And we need to have some unusual financial and non-financial incentives. I'll talk to you a little bit about bringing back the diaspora, which I think is absolutely crucial. We work in, one of my grants is a MEPI grant. This is a medical education partnership that Fogarty actually, the NIH funds in the University of Zimbabwe. Well, the University of Zimbabwe has one cardiologist for 12 million people. I mean, we have got to bring back the diaspora if we're going to make a difference. For those of you who know, I run also the Johnson & Johnson Global Scholars Program. I think we need to have bilateral exchange, not one-way exchanges. And I think we have to work on innovation. That we're going to, just like those mobile phones are a leapfrog innovation, I think we need to have point-of-care diagnostics, smartphones, telemedicine teaching, and what I'll show are health tool boxes that we're working on. So just for the end, I'd like to talk a little bit about a grant that we've been working on at Stanford. We're very lucky to get. And again, this is a horse of a different color for me. I am a clinical tropical disease doctor. I got to Stanford and was asked to build up their global health program. Well, their global health program is around technology. It's around this innovative technology. So we went and applied for this grant, which actually is how do you design, I said to my engineering school and my business school, I said, okay, why don't you work for that bottom billion people, those people that live on less than $1 a day? Why don't we think of some innovative, affordable drugs, diagnostics, or devices to improve the health in the developing world? So we developed this crazy program that I thought I'd tell you about, which is C-IDEA, where we actually build these multidisciplinary teams. So I have someone from the business school, someone from the engineering school, they can be from the med school, the law school. We throw them in an emergency room or in a low resource setting for 6 weeks. They have to come up with 200 ideas on how to make the doctor more effective, or the community healthcare worker or the nurse, how to make them effective. Then they come back to our design program, and they take those 200 ideas and they whittle them down to 5 ideas. And then they get put in our business school, and they whittle down those 5 ideas and come up with a business plan for 1 idea to make a difference. And so some of the things that they've come up with, they're just amazing, these kids. They really have come up with some fabulous ideas. So on the bottom is when we have the pandemic of flu, to have a $150 low-cost ventilator that you can carry around may make a huge difference. We have this $25 prosthetic, and for those of you who were in Haiti after the earthquake, which I'm sure some of you saw, that these prosthetics, which usually cost about $25,000, to have a low-cost prosthetic is amazing. We're working now, it's much harder to do upper arm prostheses. We've just got the lower leg. We have this great incubator that was actually featured in National Geographic as one of the leading innovations. It has a wax that you can flick the battery, and it melts the wax so that the child can be put in an incubator in the field. and kept at a temperature for 8 to 10 hours. So that's something that you can carry into the field, and that's going to cost like $25 to $50 compared to the usual many thousands of dollars of incubators. A health toolbox to have algorithms for on the spot for community healthcare workers to actually, okay, I have a patient with trachoma. How do I treat that patient? Trachoma being an infection of the eyelids. How do I treat that? A chlamydia infection. How do I treat that chlamydia infection? And you'll have a live consult with this health toolbox. So these are all kinds of ways that we're thinking about cracking eggs. But I know this audience is mostly health professionals, so how do I think we need to crack these eggs? And I'll end on this slide, is that we and health professionals are in a unique salient position to advocate and commit to addressing social, economic, and cultural aspects of health rather than disease-only approach. We should assure that food, clean water, and health are basic human rights and protected from profit exploitation. We should redesign an essential drug policy and access to targeted generic production of drugs and of breakthrough drugs. And we should broaden research in innovative, multidisciplinary ways to encompass a fairer proportion of global burden of disease. So I'd like each of you to sort of get that call of like, let's crack eggs together, and let's crack eggs together in an innovative way. So thank you very much for the time, and I'd like to open it up to an interactive discussion. Thank you.
Thanks, Michele. That was a great talk. I think actually a lot of the people who are here are still students and who may be thinking about, you know, is going to medical school the way that I can make the world a better place, or is becoming an app designer the way to make the world a better place? I mean, where do you, it's often said that health policy is doctor-centric, but in policy, but in the healthcare delivery usually doesn't have that much to do with doctors, and as you pointed out, has to do with a lot of other people. Where do you think the most critical person power needs are coming?
So
what's your advice to students?
So my advice to students is basically, you need to be passionate about what you're doing. And when you, if obviously you're interested in global health, and I would argue that you don't have to go to medical school, you don't have to get your MPH, but you can, that you can come at global health from many different ways. You can do it through, and this is what, this has been the big jump for me from coming from Yale, a very traditional medical school and public health school, and jumping to Stanford. It's just shown me a completely different way of going about global health. You can do it by doing apps. I mean, you're probably going to yell at me after this talk, but you can do it by basic science. That basic science person sitting in the lab is just as important as the operational research person. I think that there's a whole, that's what I love about this profession. I love about global health, and I think maybe that's why it's captured the imagination of so many people, is that you can come at it from so many different places. That picture I showed you, that picture number one, that's what I tried to put the two pictures that were really most influential in my life, was getting out into the field and seeing that kind of global health disparity, that baby picture of a kid with my friend's kid, and being there in the field. People say, is it worth the burden? At the beginning of my career, I sent people for short periods of time, and I got a lot of criticism for sending people for short periods of time to underdeveloped places, because you are very much a burden on the site, unless you really are leaving a legacy or building capacity. And I have morphed my program into bilateral exchange and capacity building. But I have to tell you that that sentinel experience of being out there in the field and getting your hands dirty is so important for really giving you a perspective about what you want to do. So if I can really, and there are many ways now, there are a tremendous amount of ways of getting overseas and getting yourself overseas. So that's what is most important to me. So there have been a lot of studies looking at this, and it is a very important point to make, because there's a lot of push and pull factors. And it can range from having better opportunities for your children, political stability, economics. It can be all about economics. It's not always about economics, though. There are all these other hidden, they're not so hidden actually, reasons for pulling. And I'm not saying there's anything wrong. I'm not saying there's anything wrong with that. I think we need to have incentives to keep the foreign nationals there. And I think NIH is trying very hard with these MEPI programs, these medical partnerships that you actually twin a university with another university. So we're twinned with the University of Zimbabwe. But believe me, it's very hard. It's depressing when I go to Zimbabwe to work. And I see my counterparts that are making like $25 a month and having to spend half their time doing private practice and not in the public hospital. So I understand what some of those pull factors are. But I'll throw it back to you.
Part of this big picture.
I totally agree with you. I totally agree with you. You know, I've had the pleasure of having this conversation with Ellen Sirleaf Johnson, because we're working in Liberia, and she gets it. I mean, you need to take into consideration that you need to build up that infrastructure. You're absolutely right, and all those other political aspects need to be those pull forces and push forces. They're both. You're pulling for economics, and then there are these push forces. Complicated question, But I do think we have some responsibility when we take folks that have been trained and paid for, their entire medical education has been paid for in another country, and we bring them here, that maybe we should pay back. I mean, not stop them from coming, but maybe we should pay back a remittance. Just an idea, and that's been floated of. So a lot of people think that health should be set as a global public good. And it may not be a right to health, but at least a right to access to health care. That should be held to a higher standard than just consumables.
Yeah, whether it's in fact.
I stand by my objective. I stand by my objective really strongly, that I think that that's what I'm working for.
Well,
It
is a vision.
It is a vision. It's a large vision, but if you can't, to me, that's what makes me tick and wake up in the morning. Right, so a big thing is global is local. It should actually be local. So one of the things that, when I was in New Haven and the infant mortality in Zimbabwe was almost as high as inner city New Haven, I started one of the first mobile van healthcare. This is really a long time ago, where we went along with the needle exchange van, so that global is local. We have tremendous disparities in this country, tremendous, and I don't differentiate. It's interesting. We used to be called international health, but that was more about us going overseas to helping another country. I think many of us changed and worked to change the word to global, to think about the entire world, and that it's about disparities. And back to this gentleman's point, it's about inequity. I'm sorry, I don't understand what programs you're saying. How do you get programs implemented? Oh, you know what? That's the million-dollar question. What I'm showing you are new innovations. And the question, and actually we were talking a little bit about this earlier, operational, and how do you get them to actually use it. The SMS frontline I've worked with, those are some of the Stanford kids that have gotten it out. And at the beginning it was hard because of the illiteracy and difficulty, but it's amazing how cell phone use has just dramatically, exponentially become part of the day-to-day living in parts of these worlds.
With teenagers.
Yeah, actually younger than teenagers. So we're working on the operational part. So I think you have some faculty in the public health school. Chris, do you want to take that? Or Dan, or?
Actually, Pat is the one that
or Pat?
Disparities in Georgia more than us.
Well, there are a number of clinics here in town, several Mercy Health Clinic, Nurses Health Clinic, the Athens Neighborhood Health Center, our own public health department. There's a lot of things you can volunteer for. There are activities with the health of school-age children and preschool children. Our young medical school here has very strong community outreach programs for its medical students. I know that public health students do community engagement projects. The service learning office here at the university is a wealth of information about how you can get outside the UGA bubble and into the permanent Athens, where the poverty rate is 30%, which is the highest in the nation for a county with a population of 110,000, 115,000
Wow.
people.
What are some of the biggest concerns in terms of public health for our county?
Well, poverty, you know, it's really bad for your health. So we have a tremendous population of working poor people here who don't have any employer-supplied health insurance and who can't afford any health insurance on their own. And there are a number of safety net programs that are, we hope, expanding all the time. Are you in people, parasites, and plagues, or are you in the? Yeah. Yeah. Well, you might want to look into some of the public health courses that are taught here.
Also, you might look into, as the Affordable Care Act comes through, what actually your state is doing and how you can get involved in that.
Our state is not doing much.
Not? Well, it will have to. It will have to. Well, if you want to work with ministers of health, you better get used to it. I mean, it's all about politics, at least in my experience. But that doesn't mean that, I mean, you have to be respectful of working with MOHs, ministers of health. I mean, you have to, when you're a guest in a country, you're obviously going to work with them and try to work within their policy. For instance, you try to use the essential drug list that they're using. You try, I get really angry about bringing in short donations of drugs that are not on the essential drug list, where it's not sustainable and that you have no legacy. You need to work within the boundaries of what your MOH is. Well, I think you're interested in doing faith-based work. There's tremendous, yes? Yeah, no, there's tremendous amount of good work that's been done by the faith-based organizations, and I would just surf the web. I mean, it happens to be not the route where I've gone, but I have interfaced with those folks tremendously. And, you know, there's some great fellowships, the MAP Fellowship, which it eludes me what MAP stands for, but that will set you in. World Vision is another faith-based NGO. What else?
Well, the Catholic Charities.
And, Catholic Charities.
Like in
right.
Haiti, they were huge.
I mean, I started with Catholic Charities with Refugee Health. Well, these are through non-governmental organizations. You can go into these charities and work for these charities. There's no reason you can't do that. Now, I do.
I'm just wondering, like, how to find all of those programs that you send.
I would, the web, just surf the web. And, you know, I have to another program for those of you who are interested in the Peace Corps is that I've been working on a medical arm of the Peace Corps. So as of this year, December 1st, you can actually apply to the Peace Corps and spend a year to 2 years overseas and get debt amnesty for your medical school training. So, or for your nurse training. So this is a new aspect of the Peace Corps. I think we have a lot to learn. I mean, that's, at Stanford, we're calling it reverse innovation. We have a lot to learn. You know, I spent a lot of time in Cuba because I was on a foundation in Cuba. You know, the way that they have a team that's assigned to an apartment building in a block where that doctor, nurse, and medic has everybody in that apartment building and is responsible. It's a pretty amazing way to go about healthcare. So we have a lot to learn. I think if that's what you were trying to pull out of me, you pulled it out of me. My whole point for sending physicians overseas is to actually let them see that you can actually practice medicine without an MR scan, without a CAT scan, with actually being able to go back to the bedside. That's one of my hidden agendas, or not so hidden agendas, because I'm very upfront about it. I think there's a lot to be learned from working in that setting, in a low resource setting. We're just in the midst of doing it this year. I can't give you the statistics yet, we just funded it.
Okay, thank you very much, Michele.